coming to people management.
Correct.
So how you handle that?
People management is the toughest thing in any business.
Okay.
So if you don't build a team and if you don't have a team who can manage your practice, then you have failed.
Okay.
The common problem as dentists, what we do is when you put a shoe as a dentist, you try to micromanage everything. Yes. You tell your assistant, no, this is not packed correctly, that is not arranged correctly, this is not given to lab correctly, why this is not come, why appointment was not fixed, why bill is not put.
Okay.
When you go into an administrative side, so you should only focus this, you should not talk about a clinical thing.
Okay.
So when you are a clinician, having both the role, that is a problem which most of the clinical practices, because you try and do this as well as this. But if you are able to segregate this among yourself, when you see your accounts, you have to see it as an accountant only. How much did I buy? How much did I spend? What I charged? What I got? When you sit as a clinician, you talk only as a clinician. Okay. Simplest example. For this case, I can put a graft, B graft situations. But what is the cost? What would be the outcome? You should always keep because outcome, if you are compromising, your practice fails.
Okay.
The practice cannot fail. But on this choice, without compromising the outcome, whether you can make your income profitable, you have to choose that.
Okay.
So simplest example is, all of us know a dent care crown is best. But somebody charging a 3,000 rupees, if they want to, for a metal ceramic crown, when they give it to a dent care, which is 1,100 rupees, you're spending 40% of the cost for that.
Yes.
Reversely, when somebody charging 7,000, not giving it to dent care is also correct. So that way, you should have a unit economics very clear that what we charge, whether what we use is justifiable.
Okay. So there is something called money embezzlement.
Correct.
Pilferage.
Correct.
So how are you preventing this? Have you faced that kind of problems?
Yeah, that is something intentional privilege is happening, unintentional happening.
Okay.
In every practice, unintentional you cannot avoid, and the only way you can try and reduce it is to set processes. Common things, you get a lab analog. Implant is placed, lab analog is sent, the model comes. Commonly the models we throw. The assistants doesn't have knowledge. Okay. So with the lab analog or with the coping, they throw those models also. Okay. So this is unintentional. So you cannot find. But these things you have to only bring an SOP. So implant, single chair side operates. All models has to be one, cut the model, take it, write a baggie and keep it. So this kind of thing. Intentional is sometimes, most of the things are not commonly seen, but here in our practice, how we try and do is, we try and make everything accountable. And we incentivize everybody's performance linked to the performance. So if a clinic does X amount, the assistant, the front office, the doctor, everybody gets incentivized. So it's a maker-checker formula. So if one of them is having some Western intention, the other two will also lose their earning. So that is where the maker-checker balance will do it. If all of them group, you cannot help it. So that is different. That is where as a promoter, you should know what is my regular earning, what is my outcomes. Suddenly something goes down, then you will get that alarm. Okay. So suddenly the walk-in is same, the revenues dipped 20-30%. My material expenditure is not going. You have to correlate.
Okay.
So same walk-in, revenue dip, material same, then something is wrong. So that is where your alarm clicks. So is some treatments not getting billed, or the billing is not getting accounted. So these kind of ways you have to have all these mechanisms to find out.
Okay. Sir, this kind of auditing, are you doing, or you have a team?
We have a process basically. My purchase always works out on number of patient, consumables given to that clinic, revenue of that clinic, what percentage is happened. So he does month on month. When there is an escalation of few percentage, he will bring that to me. Then we go into the case sheets. Then we match it. So then you will easily find.
Sir, you have told about the SOPs, standard operating protocol. So you have every SOP for your...
simple SOPs we have. The formulas are very simple. Whenever a patient comes, we talk from the patient end. Whenever a patient comes, they are supposed to approach the patient on 3 aspects. For what chief complaint they have come, that has to be addressed. So what is the complaint? What is the treatment? What is the cost? If they are not getting it done, why they are not getting it done. Second, what are the other complaints they have, whether it has been explained, this is good if you do it now, if you don't do it, this is where you will land. So that the case sheets will be chief complaint, other complaints, benefits of doing, problems faced of not doing. Third should be, what are the future preventive things which this patient can do. So there can be a missed tooth, you have recommended, he is not taking it, you have to tell, if you are not replacing, the tooth will collapse, you will have food impaction. So after 7 months, if you are getting food impaction, you give us a call, we will tell what is the solution. So this is the third thing we call it as predictability of the disease. So on these 3 grounds, we try and train. Second, on individual treatment, whatever we recommend, we always try to tell a patient, tell our team, you have to approach a patient bottom up or top down. And the treatment choices, if we have 30 clinics, all the 30 should give the same. So that is where the brand's faith builds in. If a patient walks into our practice, when we say bottom up, simple to the complex. If it's top down, complex to the simple. So if there is a missing tooth, our dentist starts, sir, you can do an RPD. If the RPD is something which you don't want to put it inside the water and keep it overnight, you can do a cast partial denture. Cast partial denture is something which you need not put it in water, but still you have to remove it. And if you don't want to put anything removed, you want to do it fixed, we can do an FPD where we grind both the tooth. If you want the grinding to be lesser, you take a zirconia. If you want it to be little more, you can take a metal ceramic as well, kind of thing. If you don't want the grinding at all, we can place an implant. But implant, if you place, you'll have to wait for some 30 to 90 days. After it osteodegrades, you have to go for a crown. So in this process, we have taken from an RPD to an implant.
All options you are
telling. And never in this conversation, we have told this is best, that is bad. So everything has its disadvantage, this has its benefit, kind of thing. So when you tell this as an open thing to the customer or to a patient, they feel you are transparent. He might afford an implant today. But when you tell no cast partial, nobody wears nowadays, it's an olden technique, and he is going to be uncontrolled diabetic, then you have killed your opportunity to sell that implant nor that cast partial. So that is where you should be transparent enough, give all the choice to the customer, and the patient can take your help to pick what suits him. This transparency, if you are able to bring to every treatment, in every clinic, every patient, every time they come, then that is where the trust.
Trust and loyalty.
Even the Queen of England doesn't want to be overcharged. So that is where you have to build that trust.
There is a common misconception among certain people that going to a corporate hospital, they may charge more, and the treatment may go unethical, unnecessary treatment they may do. How you are addressing these challenges? Even doctors, they have this.
This today healthcare, for that matter, forget corporate clinic or corporate hospital.
Generally.
Because post-COVID, people look doctors as money-making machines. Basically, this only should come from the person inside. So only thing is we have to always remember we are in a service industry. So typically medicine, when it was started 50-60 years back, it was started to serve people, not to earn money. But slowly it became a livelihood, now it became a business. So it doesn't mean that you have to be taking it as a money-making machine. So that compassion, love and compassion will only help you sustain longer. So that way, if you have a standard price list, and if you have a printed chart, put it in front of your table. First thing the customer will know, he is transparent.
There is no hidden.
No hidden. If you can make it as a board price list and display it, even better. So which means you are not worried to disclose what is that you are going to charge, and you are not going to change it for anybody. You take a reference and you go. Second step is, if your charges are higher or lower, in either case, if you are able to explain and justify why you are high or why you are low, then it becomes even better. So once that trust and belief happens, then it becomes easier. So generally at scale, corporates can become cheaper as well. But sometimes because of their overheads, it might be little expensive than a neighborhood clinic also. But once again, it is all about you justifying the cost will get your customer satisfied.